Today we're going to continue our discussion about peripheral vascular disease. Remember, this is the plumbing that brings blood flow down from the heart to your rest of your body, the oxygenated blood that you need for tissue survival. And so the last video we talked about blockages in the lower extremity circulation that can lead to symptoms of what's called intermittent claudication. I walk a certain distance, I get tightness in my calf muscle that stops me from walking. I stop, it goes away. I start walking and I get the same thing. I walk up a hill, it happens quicker, or if I walk fast, it happens quicker. It's very, very repetitive. It's not like one day I have this and the next day I don't. That's not peripheral vascular disease and intermittent claudication. So every time I walk the same distance, I get these symptoms. Or you can have peripheral vascular disease that's not symptomatic, meaning that the patient has blockages but not having any symptoms. Either way, just to summarize the last time, intermittent claudication does not generally need intervention unless it's lifestyle limiting, affecting the quality of your life, and you've tried to be conservative about it, the smoking cessation, blood pressure, cholesterol, blood sugar control, exercising program, plus or minus some medications like Platol that can potentially help you walk better. That's intermittent claudication and peripheral vascular disease. Now, it's a continuum, right? So what's the next worsening step of peripheral vascular disease? Well, it's a group of symptoms or signs and symptoms called critical limb ischemia. And so, as the name implies, that's when we start worrying more about circulatory problems. One is lifestyle altering. Critical limb ischemia is limb threatening. You're at a risk for losing a leg from the hardening of your arteries. Now, that doesn't happen very often, particularly if you're not smoking. That's the key. But when people have peripheral vascular disease, that's always our concern, is one, critical limb ischemia, and two, heart disease and carotid artery disease that we talked about. So critical limb ischemia is a different entity. It's part of the continuum of peripheral vascular disease, but it's treated differently. Why? Because the risk of limb loss is a lot higher. Okay, so if your peripheral vascular disease becomes bad enough where you have critical limb ischemia, well, what are some of the signs and symptoms of that? Well, the classic is rest pain of the toes or the heel. Rest pain, as the name implies, is pain in your toes, particularly at nighttime when you elevate your legs, or pain in your heel at nighttime. I go to bed, my toes or my heel hurt terribly. It wakes me up every night. I have trouble sleeping. And it's, again, very repetitive. It happens every time I go. Well, what makes it feel better? Well, when I lower my leg down. Okay, why? If you lower your leg down, then the blood flow is able to get down to your foot a little bit more. And so think of this, the physics of this whole process. Here's a tube of blood. If it's critical limb ischemia, where's that problem going to end up? In your toes. That's the end point, right? And so if you start having rest pain in your toes, that means your toes are saying, hey, I'm not getting enough blood down here. I need more circulation. Okay, so rest pain of the toes turn funny colors. There's something called dependent rubor. You lower your foot down, it turns kind of bright reddish, ruddy kind of complexion to it. Dependent rubor looks better when you elevate your legs. So that's critical limb ischemia, rest pain, but also it can lead to tissue loss. I have a sore on my foot, or I have a sore on my toe, my heel, that doesn't heal up with good wound care and avoiding any pressure on that point. So not everybody who has a sore in their foot or toe has critical limb ischemia, but if it's due to critical limb ischemia, then it's a bigger deal, okay? So what do we mean by that? So as you know, diabetics get neuropathy or loss of sensation in their feet, and they can develop wounds on their feet or toes just from repetitive pressure or prolonged pressure at one point. They develop sores in their feet. The difference between critical limb ischemia and diabetic neuropathic ulcers or wounds is that the neuropathic ulcer is from pressure and lack of sensation rather than pure arterial problems, although there can be both factors that are involved in wounds. So Pure critical limb ischemia is rest pain of the toes, non-healing ulceration of the toes, and gangrenous changes of the toes. The toes turn funny color, dark, turn gangrenous, and that can be, categorized into wet gangrene, dry gangrene. Not something that you want to encounter or discuss openly in mixed company, but those are the situations where you definitely need something done. Okay, so why? Again, the risk of limb loss. This stuff can take off on you. You start spreading upstream. You start having wounds, sores, gangrene, and it spreads upstream. You start losing toes, legs. Obviously, if you start losing a leg, your mobility is not going to be as good. So critical limb ischemia is a condition where there's no conservative management. Because critical limb ischemia needs intervention. So says who? Says most of the major societies. The Society of Vascular Surgery guidelines, what's called Task 2, that's capital T, capital A, capital S, capital C, dash Roman numeral 2 guidelines, even the Medicare guidelines, so-called MedCAC, capital M, capital E, capital D, capital C, capital A, capital C, 2015 guidelines, American Heart Association guidelines, 2016, for critical limb ischemia, all recommend angiography and intervention, or an angiogram, X-ray dye test and intervention, be it endovascular intervention or minimally invasive, or if it's something that's not amenable to minimally invasive intervention, then a surgical bypass. And that whole thing is changing a little bit. There's some nuances. There's a double-blind randomized study that came out that suggests that if you have a good vein conduit for bypass, that may be a better option. But that's getting into the weeds. The nice thing about minimally invasive stuff is that, as it implies, you don't have to have a big surgery. It's a littler procedure with not as much pain afterwards, and potentially that can make you better. But anyway, you need an angiogram and something done for limb salvage, because your risk for limb salvage is higher. So I think I read somewhere that if you have rest pain, you have a 20% chance of losing a limb within a year. That may be a higher number, but it's still concerning. And the other part of that is, if you lose a limb, your 1 to 2 year mortality, meaning your chance of dying within a year or two, is about 20 to 30%. So these kind of situations are really important to take care of. Again, critical limb ischemia, if you develop it, is not a medically managed disease. It is a intervention disease because of the risk of limb loss, completely separate from claudication. So if you have claudication and you're stable, don't recommend intervention, right? Conservative management, exercising, cardiovascular risk factor modification, smoking cessation. If you progress to critical limb ischemia, by all means, you need intervention. And then I'll kind of talk about the types of interventions, the angiograms and the surgical bypasses that we do, why we use different materials for the surgical bypasses at a later date. But I wanted to make that distinction this time between critical limb ischemia, which needs intervention, and claudication, which does not necessarily need intervention. And claudication is what I worry about in terms of procedures being done that perhaps don't need to be done. And claudication is treated more aggressively than it needs to with endovascular interventions and surgical bypasses. But critical limb ischemia definitely needs intervention. There's no doubt about that. And talking about the risk factor modification for critical limb ischemia, yeah, you want your blood sugars controlled, your blood pressure controlled, and all that stuff. But the cat's out of the bag at that point. So if ideally, yeah, you want to get your blood sugars controlled, but if you're getting to critical limb ischemia, you need something done. I had this conversation with a reviewer from a company not to be named, but this reviewer was trying to convince me that the angiogram was not indicated because the blood sugars weren't well controlled. in a patient who had gangrene of the feet. That is absolute nonsense. Nonsense. You have critical limb ischemia. Doesn't matter what your, how tight your blood sugar control is over 3 months. Yeah, you'll want it better controlled, but at that point, when you have critical ischemia and gangrenous changes of your foot, you need an intervention. No doubt about it. So anyway, next time I'll talk about bypasses and endovascular techniques, pluses and minuses of all of these things. And then we'll try to wrap up peripheral vascular disease with some other minor topics that I think patients should know about. Again, any questions about any of this stuff, just shoot me a comment below. Again, I can't go into specific details of your clinical case, but I'm glad to help give you some guidance and help you understand what's going on in your situation. And if you find these videos beneficial, subscribe to them, and I will, update these things regularly. There's a lot of vascular surgery. I mean, there's so much information, and I'm going to put out these regular videos with the hopes that people get some benefit from them. Thank you.